On behalf of Peter and I, welcome to University Hospital Southampton's annual review for 1920. Now, I'm going to talk through a few slides about the year, but to be honest, probably the primary focus of our year, like everybody else's, was COVID. And so the order will be, I'll talk about the year as it's happened. I'll hand over to David to the finances, and then we'll spend some more time talking about COVID, and then Jo can do some more detail about COVID later. Now, you'll all be familiar with this. We're one of the largest acute trusts in England with an annual income of more than 900 million. And we are CQC Commission, Care Quality Commission, good rated overall, and consistently one of the UK's highest recruiting trusts to clinical trials. So really proud of the work that we do and our status in the country. And I think that's been really supported by our work with COVID, which I'll come to later. Next slide. We've got 11,450 staff, and those amazing people see these numbers, these huge numbers of outpatients, of attendances at our emergency department, of inpatients and day cases, and outpatients. Although, of course, you may have noticed more recently that these have become a little bit less hands-on and more electronic where we can. Next slide. And in the year, we did some real work with our people to look at our vision for the future. And I'm going to just touch on two of them in particular. Our vision is University Hospital Southampton, world-class care for everyone. And this is really important to us because when I'm talking to staff, one of the things I emphasise is that for people who live in and around Southampton, for our patients who come in from further afield as well, we don't just want good care, we don't just want regional care, we believe that our patients deserve world-class care. And this is also a vision for staff as well. So our staff, the people who can make it possible for patients to have world-class care, deserve world-class care themselves, so that actually UHS is one of the best places to work in the world. I've hesitated before moving on to the for everyone, because the for everyone recognises the contribution that every single person makes, both in terms of a patient and a member of staff. So you come with the person you are, and we recognise and respect that every single time. So we look at every person as an individual. So our mission actually is University Hospital Southampton, together we care, innovate and inspire. And we asked our staff to tell us what it was like to work at UHS and what they were proud of and why they turned up on a wet Monday morning in winter. And so they came back and told us University Hospital was one of the reasons they worked here. It's something they're really proud of. The experience they get with some of the amazing and most phenomenal technical medical treatments in the world is one of the reasons they work here. But also because together, there's a family feel to this organisation. We care. And I think you can see whenever you come into the hospital, we really do care. We care for each other and we care for our patients. And yet we also make sure that we're innovative, constantly thinking about what we could do better. And I don't think anybody would disagree with me that our staff are inspirational. And they do inspire each other, and they also, from the compliments I get to see as well, inspire their patients. Our values have been around for a while. I'm going to talk through them in a minute in terms of the way that we've considered the year that we've had. But during this year, just before COVID kicked off, what we've done is we developed a new clinical strategy, and the clinical strategy emphasised the need to work with our system partners, with other health and social care partners, in being able to be successful in a future that includes world-class care for everyone. Next slide. So what have we done this year? Well, going through our values, first of all, you can see patients first. And if you look there, you can see the dementia-friendly X-ray room opened. And this comes back to recognising the individual that we see in front of us and everything they bring, all the wonder that they bring with them. We also opened Older Persons Meeting Hub, and we've done some, again, innovative gel injections, which reduce the side effects of radiotherapy for prostate cancer patients. Next slide. So our next value is working together. And I don't think anybody in this country could have ignored the consequences of the Black Lives Matter movement. And there was a moment in the trust where it gave us pause for thought. We shouldn't have needed something like the Black Lives Matter movement to have really seriously thought hard about what the experience was like for Black and Asian minority ethnic people who work and experience care in our trust. But it did give us a chance to reflect on what we'd done successfully so far, and we worked with our One Voice community to put together a feedback and action plan. And the action plan's going to the board at the end of September, and it's been a piece of co-creation that's been jointly signed off by our One Voice network. And we're really excited about the changes and the differences that this will make for people in line with our value, in line with our vision again, about world-class care for everyone and the value that every single person brings to our trust. We started construction on our new Maggie Center, and what we did when we we're working together with the wider systems, I mentioned it's really important for us as part of our strategy. We pooled resources for winter across our local system, so worked really closely with Solent and Southern to make sure that our patients were cared for through winter. And we've worked together on a joint venture with Hampshire Hospitals, making sure that we get value for money whenever we buy anything at all. Next slide. And always improving. I don't know if any of you have had the chance to go through our children's ED. Now's perhaps not the time to try to do that, but it's an absolutely beautiful space. And we're really proud of the environment and the care that we can give through the emergency department. And we also had the opportunity to open a urology day unit, and you can see the team pictured here, absolutely beaming. And it is, again, a really lovely space, which then complements the quality of care that our teams can provide. And here's this, I was talking before about R&D. So we are the highest recruiting trust for research and development. We're consistently in the top 5. We make £3 million income from commercial research. And we have over 20,000 people who can access trials. And we have 800 studies running at any one time. And I would say a great big thank you to anybody who's prepared to take part in a trial from a patient point of view, but also the tireless and endless work that our clinicians do to make sure that we can attract excellent clinical trials so that our patients can have this kind of cutting edge research and treatment. Next slide. I have a feeling that this one is for David. Just hazarding a guess, I'd say this one was for David.
I have that feeling too. Thank you, Paul, and hello everyone. David French. I'm Deputy Chief Executive and Chief Financial Officer. So what I'm going to do over the next couple of minutes is just walk through a summary of the finances for the year, and then just really reflect on what that means and what the future financial situation is likely to be for the trust. So for financial year 1920. We had another successful financial year. Our income was 912 million and we spent 899, so getting on for £2.5 million a day, leaving a surplus of around 13 million. That 13 is made up of a surplus that we made ourselves, combined with some national bonus funding. And for those that have heard me speak at these events before, UHS has been successful in being eligible by achieving its financial targets for those national funding cash bonuses. The efficiency improvements figure there of 33 million is really important, because it's both it's an expectation of both the hospital and the overall NHS that it does become more efficient year on year, and we track that really carefully. So that £33 million is made up of a lot of action by a lot of actions taken by a lot of people to make the hospital more efficient. And it's things like, how do we make our theatres more productive? How do we reduce length of stay, particularly in our elective and non-elective beds? And as Paula mentioned on procurement, how can we buy equipment, materials, consumables in the most effective way? And that needn't be the cheapest, sometimes it is, but the most effective, cost-effective product. The trust has been successful over a number of years, and that has meant that our cash balance has been steadily increasing. At the year end, it was £97 million. And what that's done is enabled really substantial programme of capital expenditure over the last few years, and in year 1920 our capital expenditure was £50 million. For those of you that know the hospital, you'll have seen the new vertical extension, fantastic building at the front of the hospital, and that's taken a really significant proportion of that 50 million. But elsewhere, we've continued our investment in the IT improvement programme, the urology day unit, as Paula mentioned, as well as refurbishing various parts of the hospital. An important thing for the reputation of the trust is the report that we get from external auditors. And again, I'm pleased to report that we got an unqualified audit opinion. And by unqualified, that's the best you could get. It means that it was clean, without any cautions or complaints from them. Next slide, Karen, please. So what does all this mean for UHS? The national bonus funding regime that I mentioned has really been fantastic for UHS. It's meant that over the last 4 years we've generated financial surpluses of £125 million, and that of course has meant that we've had cash to be able to commence the building of the vertical extension at the front of the hospital. And the hospital is some of it is new, but some of it, as you will know, is original from the 1960s and 1970s. So it does take a lot of money to maintain and improve it, and that's what we've been trying to do. Our capital investment programme, as I said, this year was £50 million, and for year 2021 will be circa £60 million. The finances of the NHS are changing. As you look across the entire NHS, what you've seen is a greater divergence between financially successful trusts like UHS and trusts that have got into really quite significant financial difficulty. And I think the Centre have reflected on that and realised that the financially successful trusts have got cash and have been able to make quite significant investments, whereas the financially less successful trusts haven't. So you've got a big disparity in the investment levels across the country that different hospitals have been able to do. Unfortunately, as I say, the UHS, we've been on the right side of that. Where we're heading towards now is more of a break-even target scenario, rather than the ability to make surpluses and create cash. What that will mean for UHS is that we're probably able or less able to generate cash than we have been in the past. And critically, I think that the capital investment decisions will be less a matter for a trust unilaterally to decide. It will be more a case of a system, and by system I mean Hampshire and the Isle of Wight collectively determining where the resources for that area are deployed. We're also likely to move from a payment mechanism where we were paid per unit of activity that we did. So every outpatient appointment or knee replacement or presentation in the emergency department would generate a tariff, and that's moving away from that towards a fixed block of money, and that will be based on a population. So big changes ahead for the finances of the NHS, but in summary, another strong year for UHS, creating the cash for us to continue the improvement programme of the hospital.
David, do you just want to say a little bit more about the financial impact of COVID on the trust?
Yeah, Peter, happy to do that. I think I'd start by saying that the NHS, compared to the many private sector organisations, was in a really privileged position, because our costs since the beginning of April have been underwritten by the government. So what the government said to us is that they would continue to pay us the level of income to match the expenditure that we've been incurring pre-COVID, and that any additional costs that were incurred as a result of COVID, and that would be things like PPE, hand gel, you name it, it's millions of pounds a month. The government has been reimbursing those costs. So for the start of year 2021, we've in effect been in a break-even situation, because everything that we've needed to spend, the government has been willing to reimburse. So as I say, compared to the rest of the private sector, we've been in a really privileged position.
Good. Thanks very much, Dave. We do now have a question from one of our guests. The question really is: do we have any partnership arrangements that do actually help us access capital? In other words, those with whom we are working that offer us perhaps some alternative routes to capital, rather than just those that come through the normal NHS funding arrangements.
Yes, we do. And as a financial trust, we've had freedom to be able to explore those other sources of funding. So two examples that we've already done, and I'll talk about a third that we're about to do in a moment. But the main entrance foyer was using commercial finance, in that the income that we receive from the retailers, so Marks and Spencer's, Costa, WH Smith, that money goes to a pension fund, who in return gave us a lump sum of cash. So the hospital in effect stands back. The retailers pay the money to the pension fund. The hospital got enough to create the new main entrance and some cash besides. So that mechanism works really well, because the pension funds can see through our balance sheet all the way to central government, and are therefore willing to lend to us at really competitive rates of interest. And of course, interest rates at the moment are really very cheap. The new car park, the multi-storey car park on site, that gave us another 800 spaces, and that really was the solution to our car parking problems over the last couple of years. That's funded in the same way. And we're about to purchase a piece of land at Adnack Park. This is all in the public domain, on which we'll build a permanent park and ride car park. And also over time, we'll transfer some of the services from the hospital that don't need to be here to that land, freeing up really vital space on site here, and that will be funded in the same way. So that's a way of using commercial funding without relying on the NHS, but doing it in a really quite attractive financial way, making use of the current low rates of interest.
Okay, thank you very much, Dave. We have another question for you, it's really effectively asking how we're able to budget over the coming few months, bearing in mind the huge uncertainties associated with both COVID and the fact that we've got winter pressures coming.
Yeah, and that's a really insightful question, because that's something that we're grappling with now. The financial architecture through the rest of the year is changing versus the first half of the year, and we're converting to a fixed block of money that the centre has determined is the right amount of money for a hospital like us to have. I suppose what I'd say is it's unlikely that the centre's forecast is exactly the right amount, and I suspect we will potentially need to spend more than that. And that's where the cash that we've been able to generate protects us, because it means that potentially for a period, if we need to do the right thing to keep staff safe and treat patients and keep patients safe, that we may need to spend more money than we've got available. And again, because of our financial strength, we're well positioned to be able to do that.
We had our first wave, if you remember, it went from late February all the way through to, well, it possibly hasn't gone away at all, COVID. And what we had to do during that period was, of course, address the immediate safety concerns. Since then, and as the numbers of cases has tailed off and the hospitalisations similarly, what we've had to do, of course, is respond immediately to getting all of the activity that we paused during that period back online, and we're trying very hard to make sure we can recover it as fast as possible. And we've been quite lucky in that we have been able to access through a national contract some of the independent sector capacity that surrounds us, and that's been really, really helpful. I've got to say, and I'll say it, I don't think I can say it enough times, that actually without our staff we couldn't have done any of this. They were absolutely amazing during the first wave, and they've been absolutely amazing continuing to work through the summer in getting services back on track. And that's despite me constantly saying, can you make sure you have a rest, please? So a lot of them did manage to get some break and some holiday, but we're motoring again. You'll have noticed if you've been in the hospital how we've had to adjust to COVID, and I suspect we'll have to live with that for a while, but we have made reasonable adjustments, and we are back on top of, certainly getting on top of the work that we're having to catch up from the period when we just couldn't do anything but cope with COVID. This is our initial COVID response that I'm talking about first, of course. And so it has been recognised that actually UHS responded really well. I think to start with, like most people, we almost couldn't believe it was happening. And I know that certainly for a while, I thought that there was nothing in my experience that had prepared me for what we had to do in terms of leadership. But I hope that I and the rest of the executive, I saw it, and certainly our clinicians, all stepped up, got over the initial shock, and moved into a really responsive and active mode for making sure that our hospital was clean and ready and supportive for patients. And we had some amazing experiences, and I'm sure you'll all remember the opportunity that came with us from having the Banksy painting put into the hospital. And that was a moment in time where it really reflected and represented the commitment and the heroic efforts that our staff did put into making sure that patients were safe. We had some real issues. Obviously, there were PPE supplies. It was all over the news. It was nothing that was a surprise. I've got to say that we did struggle with PPE right at the beginning, but very quickly we got on top of it, and we took an innovative approach to managing our PPE, and we're going to talk about that later as well. But what it enabled us to do was to work with local suppliers and providers to make sure that we never ran out of PPE. We did have challenges, but we did cope as well. Next slide. And then from then on, one of the things that we've really done is we recognised very quickly, of course, that in some ways, one of the biggest challenges was making sure that we didn't pass COVID within the hospital. It was obviously present in the hospital. So our clinical leadership, Derek and Gail in particular, came up with our COVID Zero campaign, and it's been really successful. So it's not just impacted on the way that we manage COVID in our hospital, and actually we're really proud of the fact that we have no or very little onward transmission, but also we spread that out across our system partners, so other people have adopted it as well, and our local communities recognise it as something that we do, a very clear message. You wash your hands, you wear your mask, you keep your social distance, and then in doing that, you protect everybody in our hospital and in the community. So we're really proud of the COVID Zero campaign. To be able to do this, what we did is we had quite a lot of innovation, but I'm not going to spend too long on this. What we did is, in line with our values, we immediately stepped up. We looked for innovative solutions in a set of circumstances that had never been experienced before. And you'll be familiar with some of this if you've watched the television at all, because we've featured quite widely on it. And I would just pick out a couple. Our inhaled interferon beta trial, which made a real difference to the outcomes for patients and has been adopted all over the country. Safe Fit, what we did is we took our Westfit, which was a pre-prep for interventions for cancer, and we turned it into our Safe Fit programme. And actually now people are really starting to get on board with recognising that you'll stand a better chance with being able to cope with COVID if you get it, if you're healthy and well and overall in good condition. Next slide. But this is the point that Peter was bringing to our attention. The challenges that we had were actually that because we couldn't manage the ordinary throughput for patients, nor would we want to, there was an awful lot of risk involved in coming into the hospital when COVID was at its peak. That has meant that our waiting lists are increasing. it has meant that there are people who are on these waiting lists who are really, really concerned, and so are our clinicians who care passionately about making sure their patients are supported and well. So we've put in recovery plans to make sure we can maximise our activity. We've used as much of the capacity available in the independent sector as possible. We've introduced safe distancing. We've considered how we manage to get people through the hospital without exposing them to risk safely. We've done activity in cars when it's been helpful to do pre-workup, so people haven't had to come, who've been shielding, haven't had to come out of the car to have the first phase of their treatment. And now what we're doing is we're looking at our financial arrangements from April to September and October to March to be clear that we invest our money to best effect to make sure that our patients don't come to harm. Next slide. And therefore our futures. One of the things that's been really certain is that you've got to learn from this kind of experience, and we have taken some learning. We looked at what we did well, we've looked at what we've not done so well, and as we approach the potential for a second wave, we're ready. We've taken that learning and we've embedded the positives from COVID. We've worked alongside our partners because we understand that we're not in this alone. So we've put mutual aid in position. We're integrating new services. We've made changes in the NHS that I think in my long time in the NHS, it would have taken years to do before, because everybody has come together around the need for making sure that patients are safe. And now what's next? We're pushing for CQC outstanding. I think our care has been outstanding in these circumstances. And now we've just got to be able to prove it to the CQC. And finally, and I said I'd say it and I couldn't say it enough, and I'm sure every single person on this call would join me in recognising the amazing, brilliant, brave and committed staff. They have done, I mean, the stories that I've heard about how they've managed through COVID and how they're continuing to manage, how they pick themselves up after really difficult days, I've been so impressed, and they would make you weep because they have been amazing. Our volunteers, the same. They've given us their spare time. They've continued to want to come into the trust, even though we've been saying to them, please don't, stay away for now. And now they've come back into the trust in their hundreds, ready to again to give us their commitment. We've had armies of charitable fundraisers who've generated money for us, particularly through COVID. And we couldn't have done that without the support of our Council of Governors, members and non-executives. And there's not something on here that I think needs reflecting. I would say that our non-executive directors, and Peter in particular, as chair, have been amazing supports to our executive team and the leadership teams and everybody on the front line through this really difficult period. So it's a collective thank you from us to everyone, and from everyone to you, for helping us get through this first wave of COVID and prepare for the second wave. Happy to take questions.
So we do have a question that's just come in here. So let's just see what that says. It's essentially about friends and family test, and which friends and family has been a little bit difficult over the last few months. So let's broaden the question a little bit, Paula, and ask how do we keep in touch with what our patients think about and feel about the services provided by the trust?
Well, actually, Gail's on the call now. I didn't know if this is her area of expertise, that she might want to pick that up, but I'll start, and then if she kind of flags her presence, hard to see, isn't it? Then she might perhaps wants to pick up. And Peter, we've missed a question on the vision, which I'll come back to next, perhaps. So I think it's been interesting. We do always keep in touch and try to understand what the experience of care is like for our patients. And we do it through a number of routes. And I think always one of the best is to talk to the patients themselves. We do have a friends and family score, but actually, to be honest, that feels a little bit distant. So we also have other ways of testing the temperature for staff, and testing the temperature for patients. I am looking for patients, aren't I? Yeah, and the way that we do that is through individual service pulse surveys and engagement events, so that we can hear what it's like for a patient. We also, of course, have complaints and PALs, And quite often we'll get reports that show exactly how people are engaging with the trust and what they're saying about our services. It's always a shame when we have to get to a formal complaint, but it's absolutely a person's right to complain and to get a written response. And I sign off the majority of those complaints and read them all carefully and then respond to make sure that we've answered the question that we've been asked. So there are a number of other ways, but I don't want to steal Gail's thunder if she is on the call.
I am on the call. Can you hear me?
Yeah. Yes.
So in terms of friends and family test, over the COVID period, we weren't asking the friends and family test. And actually, to a certain extent, it has run its course, because we can survey people with that a lot. We will be starting back doing it. I think my big note over this period is the fact it has been a difficult time for families and also the nursing staff, particularly over no visiting. And that has been difficult for nurses taking the responsibility of families of being representative. And for families not being able to be with their loved ones over this period of time. We did a lot to ensure that we could make contact, and we have got a patient support services hub, which we are launching to thank everybody for what they did, like iPads and communications and hearts, that little tiny hearts that were sewn by volunteers, and one was given to a patient and one was given to the family so that they could hold on to them as a piece sake. So we haven't formally over this period done FFT, but we will be doing, and I think that the issue really was about no visiting. I've noticed, Peter, there's another question about thanking student nurses and bank staff.
I was hoping you'd pick that up, Gail.
Yeah, so what I would say is I've personally written to every student nurse who stepped up to thank them. And that went up because they did an absolutely sterling job in terms of particularly third years who came onto the wards and supported us. So I've personally written to thank them, and also our bank staff as well. So yes, we have acknowledged all of the support that we've had, and people that were retired and came back in, for example. So it's important to note our thanks to everybody who supported us. Thank you.
Thanks very much indeed, Gail. So there are a number of really interesting items that we thought that you'd like to hear a little bit about. And the first one is actually a pre-recorded talk by a member of staff who actually was badly affected by COVID, but has recovered well and has actually made an amazing video with a terrific story.
Hello, my name is Laszlo. I'm a registered nurse working in the emergency department of University Hospital Southampton, and I'm a devoted supporter of the COVID-0 campaign. During the early days of this pandemic, when new protocols had been introduced in our department, I remember I was waiting for my first shift in resuscitation room, where we had to gear up head to toe in protective equipment. Before entering Greaseus, I've made a selfie with my colleagues. You could hardly tell who's who on that picture, simply because most parts of our faces were covered. Later, when I have posted that picture on social media, I have attached a comment to it saying, most of the superheroes have something in common. They are wearing a mask. Whenever you decide to wash your hands regularly, to maintain social distancing, and to wear a mask in public places, you become a superhero. What is the common feature of superheroes anyway? If you look into the comic books and see the films, there's one thing which is common in all of them. They are saving lives. And you can save a life too, or many. A life as mine, because despite the fact that I'm young, healthy, and I have no pre-existing medical conditions, I nearly lost my life during this pandemic. The very fact that I'm here today, able to tell my story, is a miracle. It was April the 15th when I had to call the nurse in charge requesting to go into self-isolation, as my wife, who is also a nurse working in a different hospital, has developed some signs and symptoms which really worried me. At that point, I was asymptomatic. But it took just a couple of days for my general condition to decline rapidly. I've developed a fever, I had constant pain in my joints, and I have experienced tiredness. Still, I was so confident that because I'm young and healthy, I'm going to go through this very quickly. And I was telling myself and others, I'm going to be fine. I'm going to be all right. Yet, a few days later, shortness of breath and difficulties breathing started. And we have noticed that the oxygen level in my blood have dropped significantly. And that was the point where we have decided to call the ambulance. The ambulance took me into my own workplace, and passing through the doors of emergency department as a patient and not as a member of staff was probably the weirdest experience of my whole life. However, it was so comforting knowing that I'm in safe hands because my work family is looking after me. The very same day, I have been transferred to intensive care where a respiratory non-invasive treatment has been started. 2 days later, it was clear that this treatment is not helping me at all. I'm not improving. I'm not making any progress towards my healing. That was the point where the doctors have made a crucial decision to step to the next level. Using general anesthetic, I was put to a deep sleep. I was intubated. I was connected to life-saving equipment. And also I was referred to a specialist treatment center in London. While we've been waiting for this transfer to happen, my condition has further declined up to a level where the nursing team had to call my wife and tell her that if she would like to have a priest for me, now would be the time. There was a huge question mark hanging in the air. Am I gonna make the journey to London alive? While I was transferred to London, the leading consultant called my wife from the ambulance, telling her that the chances of survival have dropped to 40%. And he explained to her, even if I'm gonna make it, I'm gonna spend at least 3 weeks or more on these life-supporting machines, several more weeks afterwards in intensive care, and who knows how long in rehabilitation. As a result, instead of spending 3 weeks or more on these life-supporting machines, I've been disconnected in just 7 days. 5 days later, I left intensive care unit in London, being transferred back to Southampton to a ward. And 9 days later, I have been transferred and discharged home. It's hard to talk without emotions about this difficult journey. But let me say how thankful I am for modern medical science, which created these incredible machines that played a crucial role in saving my life. How thankful I am for the medical staff, both in Southampton and London, including doctors, nurses, healthcare assistants, porters, receptionists, even members of the security team, who played sometimes maybe just a tiny role in my healing, but that tiny role was crucial. And probably my story wouldn't tell the whole truth if I wouldn't say that I'm thankful to God as well, who went beyond and above science and human knowledge and made the impossible possible for me. I was so thankful to be alive, to have a second chance. I was enjoying even the smallest joys of life, such as the taste of Weetabix in my mouth. And I was making plans on my hospital bed, which now counting them, probably they are going to be enough for at least 3 lifetimes. So why COVID-0 is important for me? 2 words, hope and warning. Hope because I meet so many people nowadays who are afraid, not simply of getting sick, but because of the consequences of this whole pandemic, which includes the economic ones as well. And by playing our small role in prevention, we can potentially shorten the length and reduce the consequences of this pandemic. And warning, because I meet also so many people nowadays who are denying the very existence of this virus, fabricating and creating conspiracy theories, while my experience says exactly the opposite. So wash your hands, keep the distance, and put on that mask. Be a superhero. Thank you for listening.
What an extraordinary film that is, displaying so clearly, as it does, the what an unpleasant experience COVID is, and how threatening to life it is, but at the same time so uplifting in terms of the way that Laszlo talks about his role in UHS and the contribution of our staff. I find that quite amazingly moving. So, unfortunately, Laszlo's not with us this evening to answer questions. I know he would love to have been. So we're now going to move on to Joe Teep, our Chief Operating Officer, to talk to us a little bit more about COVID. Now, Joe actually only joined us at the end of last year, and I think almost the first thing that fell onto his desk, sort of on day around probably week 3 or something, was the need to prepare as Chief Operating Officer for COVID, in which he's done an absolutely terrific job, I may say. But there can't be very many more daunting starts than that, Joe.
Yeah, thank you very much, Peter. And yeah, Joe Teep, Chief Operating Officer at UHS. I think it's probably the worst speaking slot ever, coming in after Laszlo is the first thing that I would say. But also, yeah, I never expected when I joined the trust, when I did, to have had the period that I've had, but it has been sort of fantastic to work with so many amazing people here at UHS. And I wanted to cover in my brief session just some information for colleagues on the review that we've done of the COVID period, and also a small section on the look forward and what's ahead for us. If we can move on, Karen, to the next slide, please. We approached this in line with our values, really, about wanting to improve and do things better by looking back with our people around how we could have managed the first phase of COVID better. We asked staff to fill out surveys, and we also interviewed all of our management teams within our care groups and divisions. And we've also done some individual areas of evaluation with teams like critical care. And we know our clinical psychology colleagues have provided us with some feedback about what it was like on the front line for some of our staff during the COVID period. So we took this to the board last month on the areas that we felt that we went well for us in the first period of COVID, but also very much a section on the areas that we felt we could have done better. And I'd like to spend, if I may, a little bit more time on the areas that we could have done better, rather than perhaps go over again some of the areas that Paula and David have covered. If I could just draw out a couple of things on this slide. I think first, I do want to say that all of our clinicians that sort of supported us through this, and our managerial colleagues, from their discussions with other colleagues around the NHS, did feel that our planning for the first phase of COVID was outstanding. And I certainly sort of felt that working with all of you, really, in terms of the advice that we got from our clinical teams and how we got ourselves prepared very early. And we also, I think, had an outstanding response from our digital teams, where we had many people enabled to work at home in short time, and they helped us change some of our models of care in areas like outpatients, where we quickly moved to telephone clinics, advice and guidance and video conferences, and use technology to change the way that we deliver our services. It's a shame we can't spend more time on this, because we we did have some really fantastic responses from many of our colleagues, but overall how our people responded was what stood out in the way that we planned for the first phase of COVID. If I can move to the next slide, Karen, this was really about some of the things that didn't go well, and these weren't all necessarily mistakes we made, but at the time we were planning for a pandemic where we suspected we may have up to 300 ventilated patients within our hospital, and therefore we made some significant plans to enable us to cope with that in the event that that happened. This resulted in perhaps some decisions that in hindsight the NHS took that may have been taken too quickly. For example, the amount of elective activity that was stood down for non-COVID patients, and particularly in our populations where the presentations for care was reduced significantly as people feared coming to hospitals and the chance of catching COVID-19. And we saw, for example, days where our emergency department activity at the busiest days can be 400. We saw days where it was less than 140 patients came to our hospital. In hindsight as well, we made some changes to our critical care capacity in paediatric intensive care. We moved to the cardiac high dependency unit to enable us to create more space for the general intensive care patients that we might receive in COVID. And again, in hindsight, the paediatric patients affected by COVID were very, very low, and we had very small numbers. And as a result of the move, we couldn't see as many cardiac patients as we would have liked in settings we would have liked. So looking back now, there's things we would have done differently. And again, as we look forward, we're trying to build in these changes into our plans as we look forward. I think the last two bullet points are areas that we definitely could have done better on. First was the communication with our staff, in that we worked really hard on this, and I certainly spent sort of many hours, in the evenings in our office signing off our daily comms. But actually on the ground, staff didn't feel that I and we communicated with them well enough. They didn't find the constant guidance coming out and the email communications easy to follow. So we know that next time we have to cascade and find better ways of communicating with our people each day to help them feel safer and informed about what's going on. That's very much about managerially how we communicated, and not our communications team that were excellent throughout and supported us all the way. And also many of our services and people felt that we didn't involve them well enough in some of the decisions that we made about their services, so they found out about things after the event because we were running an incident daily and making fast decisions. So again, there's something for us to reflect on about how we can do that better looking forward. The last slide that I've put into the presentation was really about looking forward. We're in a very strange time at the moment, that we're under immense pressure, and of course we want to treat as many patients as we can with non-COVID conditions, but at the same time we're carefully looking at the numbers and the national news and the statistics that come out daily and trying to plan for any second wave of COVID. We're doing this by a process that we've adopted, which is very clinically led. We've had Mr. Paul Grundy, in fact, our medical director, has been leading a clinical prioritisation process to make sure that now we have time to find more capacity for non-COVID patients, that we treat those that need our care the most first. So in the past, we would have treated patients in order of when they presented for care in terms of access times, but now we're looking to treat patients in a way that we make sure we see those that need us the most, i.e. those that are most clinically urgent. We're also doing our best to get as much of our capacity up and running as quickly as possible. So we're still using the independent sector Spire, the Independent Sector Treatment Centre and the Nuffield Hospital for care, and we've got most of our theatres and areas now up and running. So we're trying to then make sure that the aim of this framework is to make sure that we're looking at the potential harm in our waiting list. We're asking our clinicians to prioritise that harm for those that need our care the most, and then we're deploying our resources to make sure that we're treating those in the right order in line with need. And we'll keep this framework under review as we go into any future period of COVID. And this month we're taking a paper to our board, which is our operational plan for the next period. And it wouldn't be something that you'd all particularly want to read. It's 120 pages of stuff that we'll do, but hopefully it provides some reassurance that we're looking ahead and we're trying to actively plan for the future, as well as trying to learn from what we've learned of the first phase and making sure that we try and do things better next time, albeit we did our best in what was a really difficult period. But very happy to pick up any questions, and if anybody wants to post questions to me via email outside of this or has some feedback on anything that I've said or the first phase of COVID, I'm always really pleased to get those and always personally respond to any messages that I do get, so can pick those up either now or another time. Thank you, Chairman.
Thanks very much indeed, Joe. We haven't had any specific questions about COVID. A number of people pointing out how terribly important it is that we all support COVID zero with hand washing and everything else. We have had one more general question about digital technology, but if I may, I'd like to bring that back to the end, because it goes rather beyond COVID. So the next item on the agenda, but please, if you do have any further questions on Joe's talk, please send them through. We'll try and pick them up at the end. But the next item on the agenda is another video saying a little bit about some of the terrific work that was done in our hospital in relation to research and what that has, the benefits that will bestow in terms of future treatments for COVID.
So we saw what was happening in northern Italy and then in London and recognised the challenge that would be coming to Southampton very quickly. And we were able to rapidly step up capacity within the intensive care team and actually rapidly solve locally the ventilator challenge. And that left us in a position to be able to contribute nationally in terms of leading on national critical care guidelines, in terms of contributing to the national effort around ventilator procurement and evaluation. And we were the only centre to evaluate during the main surge a new ventilator that was subsequently MHRA approved. And we also saw the abrupt switching off of the elective pathways, and our perioperative team responded to that very quickly with a new service and study evaluating that service to help cancer patients who were unable to access treatment to be able to prepare and look after their health during that time. I think one of the strengths in Southampton was that we had a really good clinical team, medical and nursing. So we were able to produce great clinical outcomes, so really substantially better than what we see published nationally as an average. But we were also able to capture that because we had an established and strong research team who were nimble enough to capture those outcomes, describe the nature of the clinical practice. One of the things we were able to contribute to was the National Ventilator Challenge, which received a lot of prominence in the media in April, May and June, in response to the real concerns that we would potentially run out of ventilators because of the demands on ICU capacity. The Cabinet Office, working with PA Consulting, set up the what was called the National Technical Design Authority for Ventilators, and I served on that as one of 4 clinical expert opinions, and we were working pretty much daily throughout most of April and early May. And the result of that was that Southampton was the only centre to provide clinical evaluation for the first ventilator that came out of that, the Penlon ESO2. And we turned that around in 3 days, which led within another day to emergency MHRA approval for what actually has turned out to be the only ventilator to come out of that programme so far. One of the consequences of COVID was obviously the switching off of most elective pathways, including some of the really time-critical pathways. So in particular, the major surgical pathway for patients with cancer. And we've been running a very successful study nationally called WestFit, looking at preparing patients for surgery, particularly with exercise and psychological support. That study was abruptly halted because of the social distancing issues around the exercise trainers. But the team, remarkably quickly, led by Sandy Jack, turned that around, developed a new service called SafeFit, which is a virtual delivery of a universal version, so more broadly applicable version of the same type of approach. And they put that service into practice, and they also wrapped around that an evaluation. And this will probably be the sort of service that will define how we look after patients in the future, because it is applicable in a socially distanced environment or not. And they not only got that fully approved, up and running with more than 300 patients going through so far, but they managed to secure the funding in a very difficult time as well.
When we started managing coronavirus in UHS, we were in a position where we actually had no prescribable therapies, and apart from oxygen and ventilatory support, really no therapeutic intervention that we felt could alter the natural history of the disease. And as a clinician, that's a fairly unique situation to be in, having no treatments that you can actually alter the trajectory of an illness. And takes us back really to the era before antibiotics in the 1930s, where there was often a observational approach. We actually have evidence-based therapies available to us in what is in medicine's development a tiny window. And so we have evidence for a drug intervention, dexamethasone, which is now licensed for use. We have evidence for an antiviral therapy, remdesivir. We have very promising phase 2 data for a Southampton invented and developed drug, inhaled interferon beta. And we have 4 novel therapies in national studies in the core program, which Southampton has been the lead actor in. I was leading a program of research in COPD last year and about to complete a large national trial of inhaled interferon beta in COPD to treat exacerbations, which are a really important phenomenon, when coronavirus struck. And we looked scientifically as a collaborative group at the challenge coronavirus brought, and felt very strongly that interferon beta, this immune modulatory drug, could be a really important treatment for COVID. Because we had the infrastructure together, because we had a multidisciplinary, very effective team working across the hospital, university, and into industry, we actually pivoted to face coronavirus in terms of a trial design and delivery. And within 2 weeks, we'd designed a trial, gone through full MHRA approval, worked with the R&D department to get local approvals, and were ready to set up across the UK 9 hospitals in a process that would usually take 6 months or more. And that really rested on such a strong foundation of expertise and infrastructure that I've worked in many hospitals in the UK. I think it would have been impossible to do that in any other setting in the time frame that we achieved that goal. Subsequently, the trial was completed. Over 100 patients were dosed, randomized controlled trial, and we got the data out within 2 months. And the initial preliminary results look very promising. We've seen significant reductions in illness severity, rapid recovery in the treatment arm. With colleagues at Southampton and the University and the Trust, and nationally, we pulled together a consortium, the Accord programme, which is a platform study to develop not one at a time, but multiple drugs against COVID illness. And so the Accord programme has run across over 30 hospitals in the UK. It's been sponsored and coordinated from UHS itself. It has 4 drugs in programme. We've been very close working with the pharmaceutical industry globally to select the very best assets that could treat the condition as we move forward. And the COVID incidence in the UK, thankfully, is reduced. We're looking at expanding the programme internationally with the sponsorship of the drug companies, seeing the quality of the work that we've begun in the UK. And we hope to therefore deliver answers on each of these therapies in a phase 2 trial sooner by working in an international footing. And then we hope before the second wave, if we see one comes, we will have new therapeutic options for either larger trials or licensed treatments.
From an infectious diseases point of view, diagnosis is a very great strength of Southampton and the Biomedical Research Centre. Tristan Clark has an NIHR Advanced Fellowship to study and work out how to diagnose infectious diseases at the front door of the hospital. And he ran the POX study using technology he had access to from a commercial partner that actually was a point of care test for COVID at the front door of the hospital. And the hospital contributed to the budget of that study because it needed to be done so quickly. We couldn't even wait for national funding. And that was brilliant because it actually led to the evidence that's now national that you can diagnose COVID early at the front door of a hospital and use that to manage your patient flow. And Tristan's actually been seconded to the Department of Health to roll out point of care studies across the country now. So successful was that UHS funded, delivered clinical trial that linked with the research facility where the lab work was done and the Biomedical Research Centre. Without that infrastructure, that study would never have happened. So right at the beginning of the pandemic, it was clear that we were going to need new vaccines. And we've had for some time a very strong collaboration with the Oxford vaccine groups, both the Oxford Vaccine Group and the Jenner Institute, to work on malaria and flu vaccines. So when they first developed their experimental SARS-CoV-2 vaccine, ChAdOx1, we were actually the first site they approached and became an enrolling site for the phase 1 study. And then for the phase 2 and 3, the very large 12,000 person study that is happening at the moment. So as a result of our success with the Oxford trial, we've also started enrolling now on the Imperial phase 1 trial. That's a different technology. And we'll be running the phase 2 Imperial trial in the autumn. And we're going to be recruiting about between 100 and 150,000 people in the UK over the next 12 to 18 months, with most of the recruitment happening in the next 6 months, in order to secure the vaccine supply for the United Kingdom after Brexit. So this is absolutely enormous activity. Our contribution for the whole of Wessex is going to be 1/18 of that, which is between 200 and 250 participants a week needing to be immunized on new studies. By week 6, that is about 1,500 visits per week. The Immunokovic Study is led by Hans de Graaf and myself, and that's studying over 1,500 children across the country with immune problems and getting the families to fill in an online questionnaire each week to tell us whether they're having problems with COVID. And it was interesting, hardly any of them had problems during the lockdown period, and now we're extending that study to go on for the whole year as children go back to school. And a weekly report for Immunokovic goes to Professor Simon Kenny, who's the NHS England National Clinical Director for Children and Young People, and to the Royal College of Paediatrics and Child Health, as well as the specialty leads for the country within NHS England for all the major paediatric specialties. You all know about the adult recovery study in COVID-19, which has demonstrated the benefit of dexamethasone, the uselessness of lopinavir, ritonavir, and the potential harm of hydroxychloroquine. And those 3 results have changed over 150 global guidelines in the past 6 weeks. What you might not be aware of is that the pediatrics and children can join the recovery trial, and that this week we've opened a new amendment for children with the pediatric inflammatory syndrome associated with COVID. And we're going to compare immunoglobulin and high-dose steroid as the first-line treatment. And this is important because currently the first-line treatment is immunoglobulin. This is expensive and it's in short supply. And the study will hopefully show that you can use high-dose methylprednisolone in an equivalent fashion to immunoglobulin as the first-line treatment. And if this is proven, then this will impact both UK guidelines, but also globally, because countries such as India and Bangladesh and the whole of Africa and Brazil, South America cannot afford immunoglobulin and have no supply. So it's absolutely critical, not just for the UK, but also globally, that we answer this question. And UHS is absolutely at the heart and centre. But none of the research you've heard about today, whether it's the treatments, the diagnostics, or the vaccines, would be possible unless we had an absolutely rock solid secure, large infrastructure to deliver clinical research at UHS. It's not just about the clinical research facility, which is world leading and leading UK networks. It's not just about the BRC. There is absolutely no way we could have taken this on or been part of this or given people in Southampton the opportunity to take part without having so many very expert people within the R&D departments at Southampton.
Good. Well, I really hope that you found that as exciting as I did. Unfortunately, Mike, Tom, and Saul are unable to be with us. This evening. But if you do have any questions about that, we will try and endeavour to answer them at the end, as long as they're not too technical. But whenever I see that, I just reminds me of what a magnificent place UHS is, and how terribly proud we will be when we look back on this in a few years' time at the huge role that Southampton would have played in the fight against COVID. So we're now going to hear from Bob Purkis, Lead Governor. Before we do, again, just a reminder that there is an opportunity to ask just a few more questions at the end. So you might want to think about that and post them in the chat box. But Bob is, as our Lead Governor, the role of the Council of Governors is really important in providing the Trust with the challenge to make sure that we are doing everything we possibly can to deliver on what the Trust has to deliver. And the role of governors in making sure we do that is of fundamental importance. So over to you, Bob.
Thank you very much, Peter. Well, Peter's introduced himself, so I don't need to go through that. I see my role as a spokesperson for the incredible group of 23 people that we have who carry out the role of governors and give up their very precious free time to carry out that role. I think thinking about it, our primary role is to make sure that the Trust, the directors, the management do what they tell us that they are going to do, that they perform and deliver the health care provisions. That's not only world class, but that's it's implemented in this part of the world that we live in. The way we do that is we have regular meetings, we have our quarterly governors meetings, and we also attend the Trust Board meetings, and not only listen to what's going on and observe the information that we're getting, but we also have our own slot where we can raise various points, various questions that have come to us via the membership or via the public. And what was, I think, very interesting for me this year was that when we had some vacancies, 8 vacancies, they were very, very well contested. We had elections, and for the first time for some time, I think, we had some real genuine challenges and people wanting to be governors, which is great. For me, it was well contested, and it's gratifying to me in this day and age when a lot of voluntary public service is not seen to be part of one's duties in that sense. So besides representing the interests of the members, we also have, of course, as governors, some statutory functions, such as appointing the non-executive directors and determining certain remunerations and examining the annual accounts and reports, of sitting and enjoying reading 200 and something odd pages of the accounts and the reports. But more importantly, it's holding the non-executive directors to account for the performance of the board of directors, and by attending the board meetings, that's how we do it. And apart from examining the performance this year, we've had to appoint 3 non-executive directors. We've had to approve new deputy chair and senior director, and approve external auditors, review the trust's constitution, and approve the annual business plan. We do that in a variety of ways. We have the Governor's Nomination Committee, which is a group of people who sit and take part in some of the information required or some of the decisions that are required. The governors regularly attend the various board committees as observers, and we have three of our own committees: patient experience, membership engagement, and the finance and strategy committee, where we meet regularly to look at and examine all the things that are happening within the hospital and any concerns that we have. I meet regularly with Peter and with Paula to raise any of those concerns. And just to give you a flavour of some of the concerns we've had this past year, at the top, I think, of most of our concerns has been the health and well-being of the staff who have worked so hard to look after the health and well-being of others, and the effect that that may have had on issues such as recruitment, retention, and more importantly, the recognition. How are people appraised? It's not just a question of hoping that we go on and carry on without recognizing this work in a tangible way that's meaningful to the individual members of the staff. The COVID effect on patients, we've been querying that. That's some of our concerns. And what I mean by that is some of the things that we've heard tonight, the waiting lists, whether there is effective explanation given to people for the postponement, because to them, it's very hard to see what's going on in the hospital. They just see their own little bubble and their own little part. So we need more patient reassurance. The public perception and inclusion, we need more of that. We hope to maintain the public engagement through people becoming more than just members, participate, more than just stand and clap. Now get on board. We recognise we have that mixture of an ageing population and a young population, and it's looking at those preventative measures, particularly at this moment in time, of young people coming to university, back to universities, and them themselves and their parents and loved ones having some concerns about their health care and their health prevention. So we've opened up, we've gone to the universities. We now actually have 2 new young under 21-year-old governors, and that helps us, those of us with more of an aging mind, to comprehend some of the younger people's needs and sometimes some of their language and the way that they use it. But I must say that overall, we've found this year that trust has come through a very, very difficult period, as we've all heard, in some tremendous ways, some tremendous innovative occurrences have happened, both nationally and internationally and locally. And we know that this is not over yet. But we do know that from our observations, through very good leadership, sound financial handling, and dedicated and supportive management and staff who have gone way beyond the terms and conditions of their employment to keep us all safe and healthy, that as a board of governors, we are really happy and that we have this hospital, we have the staff, we have the direction that it's going in, and I think we're satisfied that the terms and conditions of their employment and our employment are good for the future. Welcome any questions that anyone may have on that.
Okay, thanks very much indeed, Bob. And I would like publicly to thank you and your colleagues for the huge amount of support and challenge that we get from the Council of Governors, with whom I must say personally I thoroughly enjoy working. We haven't had any specific questions on governors, so I would now like briefly to go back to 2 questions that have been posted while we've been talking. First one's a very specific one indeed, from John Chandler, who asks Karen whether it would be possible to have copies of Laszlo's video, because he says he thinks that it would be very useful to use with some of his friends who might not be perhaps as conscientious as he clearly is in terms of taking COVID precautions. I can't think there's any reason why we couldn't do that, but
absolutely. Yeah,
confirm
absolutely not. We can do that.
Good, we'll arrange that.
Okay.
The second question, which came up during Joe's talk, which was rather broader, Paul, I'm going to ask you to comment on, if you would, really. It was really how the increased use of digital technology can contribute to new models of care for the Trust. Would you like to say a little bit about that?
Joe, I think, is keen to take that question on.
Okay, Joe, well, if you're volunteering, well done.
Thank you, Chairman. Yeah, I was pleased to get that question, because obviously I referenced digital change in my presentation. If I could just give perhaps 3 very brief examples of what we've done and we would expect to continue to do going forward. In relation to, for example, this meeting itself and the way that we've changed that we all work, I never thought I would sit through all of our board meetings using Teams technology, and they actually run, reasonably smoothly. And the team actually have set up nearly 7,000 users on Teams over this period. We've set up 2,300 remote users so people can work at home, and that's both clinicians and non-clinical staff. So a number of clinicians now in radiology, for example, can do all of their reporting from their offices at home. And we issued in very, very short time 1,000 laptops for colleagues to mobilise different ways of working. And I think we all would say that is here to stay for us, that we will carry on to adopt that technology going forward. And that has huge impact on both environmental benefits of people not travelling in the ways that they used to, huge benefits in terms of our car parking, and obviously stress on individuals trying to come to work and park, and also giving people different ways of achieving work-life balance and supporting people in different ways to work. Clinically, we moved some of our outpatient work over this period to almost half at times of our outpatient appointments being done through remote technology rather than through traditional face-to-face measures. And many clinical teams have realised that this is a way that they can carry on supporting that model of care going forward. And I know a number of clinical consultant colleagues sort of ran their outpatient clinics again from their home, which was amazing, really, in terms of we've been trying for years to get these models of outpatient change implemented, and there'll be many of these that will be embedded going forward. And then areas such as virtual wards. So our respiratory team, for example, set up a virtual ward, so patients with respiratory conditions could be monitored and managed at home rather than in a hospital bed, which was particularly sort of innovative and something that we'd like to look at and explore going forward. And of course, we've got our own patient personal record through our own product, My Medical Record, which we've delivered here. And again, at scale, we would like to be able to roll that out to give patients much more control of their own care, and particularly enable them. A lot of patients would like to have much more access to advice, guidance, information through their own communication portals now at home, through iPads and telephones and computers, and therefore not necessarily be on a traditional follow-up outpatient pathway in the future. And so again, we're doing some work at the moment to, at scale, how we can develop that product so it's fit for purpose to be able to roll out across many other specialties other than the ones it's already been successfully used within. So it's very exciting, actually, in terms of the opportunity ahead of us. And I know it's something that you Chair, have asked for, to come back to the board as well, about how we can learn from the experiences of COVID in this sort of tragic context within which we've changed, but how we can develop that for the benefit of all of us as we look forward.
Good, thanks very much indeed, Joe. We've had one or two questions that have come through right at the end, but I did promise everybody when we set this up that we try and keep to time. So if anybody who has put a question in the last few minutes we haven't been able to answer yet, I promise you we will come back to you with a response. But as I said, I did promise we'd finish on broadly on time. So it falls to me to really bring the evening to an end. I always say on these occasions what a huge privilege it is to be the chair of this trust. And I say it every year, but I really do mean it. And I think that this evening has shown amply, once again, just what an amazing place this is, with extraordinary people doing the most fantastic things. I'd like to thank a number of people. I'd like to thank Karen Burwell for making all of the administrative arrangements. I'd like to thank all of our speakers. But above all, I'd like to thank all of you who have virtually come along this evening. This is a very important occasion of the year. And I would like to say very briefly how keen we are to get back to having our regular patients members evenings. As many of you will be aware, we have held them in person quite frequently, but as soon as COVID came along, we had to rather put things into abeyance because the effort had to be elsewhere. But I do hope that within the near future we will be able to get back to holding them, albeit virtually, for a while. And so if there's any members who've got any particular topics that they would like to hear from us, please let us know, and we will attempt to put them on the agenda when we design our next session. So I think we are about there. This is the point at which I normally say, safe journey home. Obviously can't do it on this particular occasion, but I think I will just therefore say, stay safe and remember the COVID-0 message. And thank you very much for your time this evening. Good night.